Okay, so welcome to the last session. Try not to fall asleep. I know after that wonderful lunch and the last of the last, we'll try to make it interesting enough that you won't be too tempted to sleep, okay? So this last session is going to be talking about clinical practice guidelines. Now, clinical practice guidelines are different from all these other study designs that we've been talking about. The study designs we've been talking about are original literature. So the randomized controlled trials, the cohort studies, the systematic reviews, the diagnostic test validation studies. And what we want you to think about is when you're reading a paper, any of these kinds of papers, you do not read it like a novel. You don't sit and read the paper like this, okay? No. What you do is you have the list of questions in your head. And these are the critical appraisal questions that you need in order to, you need the answers to these in order to critically appraise the paper. That list of questions is in your mind, so actually you need to learn those questions. If you're going to do EBM, critical appraisal, you need to learn the list of questions, and it's a different list of questions in a randomized controlled trial versus a cohort study or a case control study or any of those. The list of questions is different. Now, clinical practice guidelines are something a bit different now. They are summaries of recommendations. Okay, so it's not the same as the basic literature, but they are recommendations put together by groups of people, of experts, who know the literature, and they will summarize what we know and what do we as a group recommend, and then what's the strength of the evidence for this recommendation and for that recommendation. Now the thing is this, there was a study, oops, let me see if I can get this going here. Oh, okay, there we go. Okay, so this was back in the 1990s sometime, I don't remember which year, but there were all these guidelines coming out from different organizations and different places, and this was a study in the British Medical Journal that did this. They said the guidelines on anticoagulant treatment in atrial fibrillation. So the clinical question was, should you anticoagulate this patient or not? And what they did, they took 100 patients with different clinical scenarios, and they applied different guidelines to these 100, every single one of these 100 patients. And they said, according to this guideline, would you anticoagulate this patient, or this patient, or this patient? And so there were 21 guidelines here. Each of these bars is a guideline. This guideline said out of the 100, you should anticoagulate 13. Okay? This guideline said out of the 100, you should anticoagulate 33. This one said 81, and this one said 100. Okay? And you sit there and scratch your head and say, what? Ish dawa? What is that? I mean, you know, which one should I trust? I mean, this one is saying do 100, and the other is saying do 13. What do you do? Now, the thing about this is this. All guidelines are not made equal. There are good guidelines, and there are very poor guidelines. And what this session today is going to do is to give you the questions to ask critically about a guideline, whether it's a good guideline or not a good guideline. The quality questions, just like the questions about randomization and blinding and intention to treat and all of those things, these are the questions you ask about a clinical guideline, okay? Now, out of these guidelines, only 6 out of 15 guidelines were developed by groups. Most of them were written by one person. I wonder which one would be higher quality, a guideline written by one person or a guideline written by a group of people. probably the group, and maybe we want to look at who's in the group. Are there physicians and patients and nurses and relevant experts and people like that? Okay. Those who had developed guidelines within a group believed the guidelines were, quote, evidence-based. Okay, but when they looked at it, most of them had not done systematic literature reviews. They just sort of cherry-picked the articles they liked. Okay. They had not involved anyone with specific expertise in evidence-based practice, had not attempted to link the recommendations specifically to the evidence. So what's going on? This was in the 1990s they found this. So what happened was after that, and this became very clear, that the guidelines just were not adhering to any standards whatsoever. So the Institute of Medicine in the US came up with some standards for guideline development. Okay, and so these are in some of the handouts that you have now. I know the handouts are really long, some of them, so we'll project them up here. But here, so establish transparency. You want a guideline that's very clear how they did it. No hidden, nothing hidden, okay? And then conflicts of interest. Don't you think there may be guidelines being published by someone who's getting paid by a drug company to mention that drug in the guideline? Okay, what kinds of conflicts of interest there are? Who is in the group? We need very clear evidence of the composition of the group. And then to ask the question, are there people in this group of people that are needed to be there? Okay? And was there a systematic review performed? What's the difference between a review and a systematic review? A narrative review and a systematic review?
Systematic review answers a very specific question. You have a question.
Okay, that is true. A narrative review is more general, but a systematic review is very focused. But what makes it systematic? What makes a systematic review systematic?
There are categories of systematic reviews, evaluation, I don't remember.
Yeah. Well, what makes it systematic, generally speaking, is there was an attempt to get all the literature on that topic. You see what I'm saying? Did they do a systematic review of the literature? And remember the word democratizing the literature, giving even this small paper its representation, or this hidden paper, the one that no one listens to, representation at the table, okay? And then, so establishing the foundations for evidence and rating the strength of the recommendations. A lot of reviews or guidelines will say, we recommend that you do this, but they do no linking to, well, tell me what the level of evidence is. Is it a strong recommendation? Is it a weak recommendation? Do we think there's a big effect, a small effect? Okay. And then to articulate the recommendations in language that can be clearly understood, not vague. Okay. And then was there external review? Did this little group put it all together and then publish it? Or did they send it out, post it on the web, and say, anyone out there can review this and give us your feedback? You see? And then, is there a plan for updating? Okay? So this generates the main questions that you ask, though there are some others, when you're reviewing a guideline. Don't you see how these features would make it much stronger? And if you didn't do some of these, it would be a weaker, less evidence-based clinical guideline. So now, then there were guideline development groups that started springing up, you know, and then so some have different rigor or use similar methods or different methods in terms of assessing the rigor. And the problem is, have you seen these guidelines or the strength of recommendations? Have you seen class A, B, C, and X? And then you see class 1, 2, 3, and I. And then you see class 1A, B, 2, 3, and 1A, B, 2, 2, and Okay, you see all these different things. And so, and did Dr. Iorio talk about this? The grade system? I think I walked in and he said something about grade. But you see, what we need is a standard way for all guidelines. Wouldn't it be great if all guidelines had the same rating system so that you wouldn't have to learn, well, this guideline had this rating system and that guideline had that rating system, and then you have to memorize what 1AB2 means here and 1AB1 means there. So this was the motivation for this one called GRADE. And Gordon Guyatt, who works with Professor Iorio at McMaster University, have developed this. And since the year 2000, see, it was this problem here, oops, it was this problem here that led to this, because the guidelines were all over the place. So now, so there are two axes here. There's one assessing the quality of the evidence. Is it biased or unbiased? What's the quality of the evidence? And then what is the strength of the recommendation? Because you could have high quality of the evidence that says don't do it. You see, so or there's high quality evidence with strong recommendation, high quality evidence with weak recommendation, poor quality evidence with high recommendations, and poor quality evidence with weak recommendations. Okay, do you see? So you have to assess both of these. All right, let me see if, did I get everything here? Okay, so let's go on to the clinical case. All right, now, before we do that, I just want to show you something. You know, when you are doing evidence-based medicine, what you're actually trying to do is start with framing the question, and you know that, right, PICO. And it just seems so simple. But it's really important that you frame it and you discipline yourself to frame the question. Now that question emerges from where? Where does the question emerge from? The case. So this clinical situation here, you develop PICO or PICO from that. Then you use those terms to search. So the very first, very practical point about PICO is these are the terms from which you actually begin to search. Then once you search and you find your papers, then you get a paper. And then the other thing to remember is there's a PICO from the paper. The paper has its own PICO. So you've got a PICO from the patient and PICO from the paper, and your job is to see, do these match? Do these fit? Can I use this paper over here for my patient? Okay? So what we'll do, somebody read this scenario, and then let's read the scenario, and as you're reading it, as you're reading it, come up with PICO. And we'll write PICO on the paper here, but go ahead and somebody read it, and then let's think about how would you frame this question into PICO.
We have a 36 years old female patient who will have followed for 3 years for obesity and hypertension. Presented here she's pregnant, 13. She wants to know if she's taking Wisconol for hypertension and what are the risks of adverse outcome of this medication to her baby or herself. Physical examination, she is afebrile, pulse is 72, respiratory rate is 40, BP is 142/89, lungs are clear, cardiac examination reveals normal S1 and S2 with a grade 1 systolic ejection murmur, there is no pedal edema, and labs are normal.
Okay, so let's frame this out. What do we know about this patient? So let's just think here. Okay, so she's pregnant. The population, let's just say some things. She's pregnant, hypertensive, obese, on metoprolol, right? First trimester. Okay, so when you have this list of characteristics for the patient, you do not use all of these in your population. What the P for population, what you have to do is you have to say, what this is, what demands do you make on the paper that you're trying to find that says that that population is inside this paper? So would it be, and it's all clinical judgment, so would it be important that she's pregnant? Yeah, I mean that's crucial, right? So among pregnant patients, does it matter that she's obese? No, so I don't need that. Does it matter that she's hypertensive? Yes, okay, pregnant and hypertension. Does it matter that she's on these? Well, that, yes.
To say it's in stage 1 hypertension?
Okay, we could say mild. We could, mild hypertension. We could maybe put it there, but so in pregnant women with hypertension, let's just say. And then what's our exposure? Exposure and yeah, our exposure is going to be, let's say, beta blocker. Compared to what?
Other antihypertensive drugs.
Okay, other
Or
hypertensive drugs. Or nothing.
nothing.
Or nothing.
We mentioned that she's first trimester.
Well, yeah, so the mild hypertension first trimester pregnancy is kind of a subset of each, right? She's mild hypertensive first trimester pregnancy, but let's just back off a little bit and say pregnant hypertensive, okay? And we know in our mind, we know that it's, see, because it may make a difference whether it's first trimester. So you have to, let's just put it here, first trimester, okay? Now, what are the outcomes we're interested in?
Increase in adverse effect.
What's that?
Preeclampsia and eclampsia.
Okay, so so for the mother, what kind of outcomes? Eclampsia,
And preeclampsia.
pre-eclampsia. Okay. What else? What's that? Yeah, like, you know, deaths from these things, but how about for the infant or the baby? Birth defects? Intrauterine growth retardation? Low birth weight? Yeah, so this would be like spontaneous abortion
Congenital defect.
and things like HELP syndrome or whatever, you know, bad things and so forth, right? Okay, so wow, there are a lot of outcomes here.
Can we just say affect or not affect?
Yeah, but let's try to put it in here now. Now, here's the thing. If I want to find papers on this topic, look at all these terms we have on the paper. How do you determine what is the way that you will decide which terms on all these, out of these, that you will use in your search?
You need guideline.
You need a guideline.
Nice guideline. I mean,
Okay, I'll give you a guideline. You want a guideline? I'll give you a guideline. So here's the guideline, or let's say what you do is say you play Sesame Street, okay, and you say, let's pretend. Okay, let's pretend. I'm going to pretend that I am writing the paper that I want to find. Okay? And I say out of all of those there, what words would have to be in the title? Have to be in the title. You couldn't write it without that word in the title. Okay. So
pregnant.
okay, pregnancy you would definitely need.
Hypertension.
Hypertension you definitely would need.
Beta blocker.
Okay, now the thing is, yeah, So beta blocker, let's put it there. Do you need eclampsia, preeclampsia? Would you have to have those words? Birth defects, low birth weight. You do this with any study when you're doing a literature search, like with clopidogrel and stroke, right? So TIA, clopidogrel, stroke, you find the words that have to be in the title, must be in the title. So we've kind of identified this. Now, then you have to say, what are some synonyms for these? So pregnancy, well, there's not too many synonyms for pregnancy, okay? And then there's hypertension, high blood pressure, so let's say high blood pressure. And then beta blocker, there would be a lot of synonyms here because you could say anti-hypertensive. So this gets a little complicated. Hypertensive, antihypertensives. Yeah, so you could say ACE inhibitors. You could say a lot of different synonyms here. So this one gets a little complicated to try to search. But let's just suppose we chose pregnancy. And another word would be treatment, right? Just treatment, right? Treatment of hypertension. So let's say pregnancy. Now, would you say pregnancy? Would you type that in? Because I can think of some words here. There's pregnancy and there's pregnant women. And if I put pregnancy, CY, it's not going to find titles or papers that have pregnant women. You see? So you have to think, should I shorten this? And then I put a star, an asterisk there. That will find pregnant and pregnancy, pregnancies, okay? So that, and what do I do? And or? And. Pregnancy and hypertension. Okay. Now, what am I going to do about this treatment up here? Okay, then I would say and. What? Treatment. And here you can put the ors. Treatment or therapy or hypertensive, or beta blockers. Okay, now we're getting a little complicated. This term is quite complicated. This is not the usual term, but sometimes you run into a term like that. So let's say beta blocker. Now, if you do this, if you type into PubMed, pregnancy and hypertension and treatment or therapy or antihypertensive or beta blocker, how many papers do you think you'll get? You're going to get a lot? Did you say gazillion? Yeah, gazillion. There'd be a gazillion. There'd be a lot of them. Why? Well, what you have to realize is, where are they actually searching for these words? Where are they searching? Like, let's get a paper out here. Where are they actually searching in the paper? Everywhere in the paper. So can you think, do you think there may be some paper that has pregnancy somewhere in it and hypertension somewhere in it and treatment somewhere in it? So how do you get this? And let's say you did this. Out of those gazillion papers, how many of them will actually be in the topic you want? Not a big percentage. But, and I heard somebody say it, and I think probably you've already had Dr. Abir's talk. What is the best way to hone in on what you want? Yeah, so you put the bracket, title, like that. and then and hypertension in the title. And the thing is, now, if you just imagine the universe of papers that have pregnancy in the title and hypertension in the title, and by the way, hypertense, I would just say hypertense star, because hypertensive, hypertension, right? Pregnancy in the title and hypertension in the title and treatment or therapy or antihypertensive in the title. What percent of those papers that you would get from that search would be relevant? 20% only? I think probably more, probably more. There will be some that are not relevant. But if it has pregnancy and hypertension and therapy of hypertension in pregnancy, do you see? See how you could, it will get the ones that you want. That will revolutionize your searching. How many of you have just given up on searching because you say, Mark Faida, right? I just searched and I can't find anything. Well, this will help you. So be sure to use this little guideline. So now you have a guideline of how to approach this stuff, right? Okay, so now you do your searching, and then now what we're going to do is, so we did that. Pregnant women with mild hypertension, does treatment with one class of hypertensive compared to another decrease the risk of all of these things? We already did that. So now, the best place in the World Wide Web to go for guidelines is this site right here. Guideline.gov without an E. That shouldn't have an E. It's just guideline.gov. Okay? Go to that website, and this is the website for the Agency for Healthcare Research and Quality. It's a US government website that collects guidelines. Now, the thing about this is, not all the guidelines on here are perfect, but they do have certain minimum standards. So there are certain things that they don't allow on the website. So if you find it here, at least they've done a first pass of getting rid of bad guidelines. But you still have to do the critical appraisal. Okay? So if you search this site and you just say hypertension and pregnancy, like actually since these are guidelines, what words would you actually search? Pregnancy and hypertension, probably. Or you could put pregnancy and hypertension and therapy. You could do that. Okay? So you go here. If you do this, hypertension and pregnancy, you could put diabetic foot, you could put whatever, guidelines for treatment of atrial fibrillation. Hypertension and pregnancy, this is what you get. There are 24 guidelines. Okay?
Excuse me.
Yes.
All of them must be US guidelines?
Just watch. See here? This is, they will tell you, National Collaborating Center for Women's and Child's Health, National Government Agency, non-US. So this one, number one, this is from UK. Okay? This is from UK. Then number two is from Canada. Number three is from US. Okay? Now, so you can look through these guidelines. You can actually, this button up here is kind of nice because you can do a compare the guidelines. So we'll do a cross-tabulation on a number of factors and show you a comparison of the guidelines. Now, so you look at this and you decide, well, I kind of like this one, UK and Canada. I wonder what the US. So you go and you click on this, the blue part, and it will bring you the guideline. Except those greedy Americans, you have to pay for that one. Go figure. So you say, I'm going to give up on the US one here. I just skip that one, and I'll just look at these two, okay? Because they're free, okay?
The most recent one.
Yeah. See, they get you, don't they? They know. So you say, well, okay. So you decide to download these, and this costs a fee, so you forget it. And then this one, a helpful friend of yours searches Google and he gets a guideline off of Google. Okay, so now we have 3 documents. We have document 4, 5, and 6. Okay, they're all on your, you can access them. Okay, so what we're going to do for the rest of the time is to review these guidelines. Now, but I need a guideline. What time do we have to finish? Can you check? 3, I think 3 o'clock. Oh, I was starting to have, palpitations and chest pain. How am I going to get through this in 20 minutes? Oh, yeah, okay, good. That's even better. Okay, good. So we have good amount of time. We are going to review these guidelines, but here's how it's going to work. Let's see, 1, 2, 3, 4. Yeah, you can decide which one you want to be. We're going to divide into 2 halves here. Okay? This half is going to, do you want to be Canadian or UK? You can't even make up your mind. It's kind of like the US Congress. Okay, why don't you be Canada and you be UK over here? So why don't you come over? And so what we're going to do is answer the questions from the guidelines, okay? Now you're going to have to look up the guidelines on your laptops or iPads or whatever. And what we will give you, we'll give you the page numbers on which you find the answers. Because one guideline, I think, is 150 pages or something. So, it's going to be hard to find. But we've done the hard work and kind of found the answers. But, okay, so here you go. The first question is the composition of the authors and the group. And then is there conflicts of interest, okay? So in Canadian, look on page S1. And the nice, look on page 6 with the little, the Roman numeral 6, okay? And you can tell me what the authors are. Who are these authors? Who are the authors, okay? And do you think that this is a good composition or is it not? Or do we not really know? Maybe they reveal it, maybe they don't reveal it. So, and we're going to have a competition. We're going to see who does a better job, Canada or UK. How about that?
Will it put them online?
It's online, it's on the website, or on your flash. Do you have your flash? Yeah. What's that? SOG is Canada.
That one?
Journal of the, yeah, this one. This is, that's UK, I think. The Royal College, that's UK. So, but you're Canada, right? You all, wait, did I mix? You're UK, you're Canada. Yeah, good. Okay. So, all right. And you try to find the answer together, and then try to be quick about it. Okay, tell me who is in the guideline group. Whenever you're ready. Yeah, so, but don't just say the number. Find out who it is. So who's ready to, is Canada? You're all ready. Okay, this one is, which one is this?
UK.
This is UK. Yeah. Look at this. General practitioner, deputy director of midwifery, consultant in OBGYN, consultant neonatologist, consultant anesthetist, action on preeclampsia, patient and care member. So this is a patient representative. Oh, whoever thought of inviting patients to come and be a part of the guidelines? That's a good idea. A retired senior lecturer. Oops. What else is in here? Consultant obstetrician, professor in obstetrics and gynecology, consultant in maternal and fetal medicine, consultant obstetric physician. Then you have research fellows, 3 research fellows, and co-clinical director of women's health, information scientist, senior research fellow, director of guideline development for the Health Economist, and senior information scientist. And you look at this and you say, what do you say? MashaAllah. They got a big group of people here together, not just one person. This is a bunch of really serious experts. And then you have external advisors and everything. So how would you rate this in terms of quality? Or now, I don't really know these people, but I'm assuming, you know, they know kind of what they're doing in the UK most of the time. Okay, so you have, at least they're being very open about who's on this committee, right? So what would you give this, an A for UK? A, okay, good. So then, let's look at the Canadian. Here are the Canadian. So here, principal authors. Laura Meiji. Really, Laura Meiji? Michael Halawa. Yahlela. And you look at and you say, wait a second, who are the? Oh, this is MD, MD, MD. Okay, we know they're MDs. I think they probably know what they're doing. Yeah. But do you see the difference? Yeah. Like, so would you give them an A or a B? A D. A D. Okay, okay. So, okay. But see, so here's the first stop. Who did it? Do you trust them? Now, this is the Canadian Society for Obstetrics and Gynecology. Now, I think they know what they're experts, okay? But do you see I'm not saying that they're not good. I'm saying the quality of the guideline is a little bit less because of that. We're assessing the quality of this guideline. Do you see? Yes?
How do I know it's less Western?
Well, I wish I knew who these, are they professors? Are they practitioners? Are there any nurses here? Are there any patient advocacy groups? Because patients may have something to say as well. Like, are there anesthetists here, or, you know, like what, because they would know something about preeclampsia. And, you know, so you get your experts together, okay? And so anyway, see, these BSCs probably may be nurses, but I don't know. So I don't really know who's on here, but okay, do I throw the guideline out because of this? No, I mean, look, it's a good society, so hopefully they're doing a good job. Okay? So that's the first one. Now, the other thing is conflicts of interest. You need to find something in there that says a statement about conflicts of interest. Now, I have searched through the Canadian one, and I haven't found it, but it's a long document. But there is one in Appendix B in the UK. So let's try to find that in Appendix B. Here. So Appendix B is on page 221. Okay, here. Declarations of interest. Okay? So, do you see this here? Chris Barry, no interest declared. Jane Howden, personal non-pecuniary interests. She's the chair of the Breastfeeding Manifesto Coalition. So she says, look, I'm the chair of this thing, and so I might be pushing breastfeeding more, you know. And non-pecuniary means there's no financial, she's not getting any money. Personal pecuniary interest, money. Consultant to Almair in relation to the development of point-of-care testing for placental growth factor. And so the idea here is not that nobody can have any conflict of interest. It's, are they disclosing the conflicts of interest? Are they disclosing them? Well, if they hide it, that's not right. You know, I guess, but people usually find these things out. And the thing is, we're going to find out later, did they put these things up on the web for everybody to see before they got published? That's another, remember that thing about transparency? If you say, I don't have any interest, and then someone says, well, yes, he does. He's getting money from Bristol Myers Squibb. You know, like, you put it up there and then the whole world can see. So, you know, it's very foolish to hide things like that. And besides, it's just not right. Okay, so look at that. Everybody is saying, see here, personal pecuniary interest, advisor to Roche Diagnostics. Okay, he's putting it up front. I'm getting money from Roche. Does that mean he shouldn't be on there? Not necessarily, but maybe when it's talking about whether you're going to use Roche drugs or other drugs, he should recuse himself, you know, and say, I'm not going to be part of that decision because I'm getting money from something, so I will recuse myself from that decision. Okay, so now I couldn't find it in the obstetrics and gynecology one, but maybe it's there. But certainly, do they get an A? Okay, UK gets an A. I don't know how to grade them. I think we'll do an average and just make it C+. Okay, so all right. So that's the second stop. See, it's not that hard. It's not that hard, and it makes a lot of sense, right? So let's go down to the next page. Conflicts of interest. Okay. Now, what year was the guideline published? So here's the thing. 2008 and 2011. The longer or the older it is, the less you can rely on it. And actually, 2008 that's 9 years ago. That's really long ago. That's too long ago. In fact, I'd like to see it even closer than NICE, the 2011. And I got this maybe 3 years ago. I developed this thing, so there's probably new ones out. Which means, you see, another question here at the end, probably down on this slide, do they have a plan to update? So we'll see if they have a plan to update, and maybe there's an update that's already come out since we developed this thing, okay? And all right, so the time of that guideline is really important. Try to get guidelines that have been published within the last 3 or 4 years, okay? Try to find that, because you know medicine is always changing, right? Okay, next question. Are the methods used to produce the guideline clearly documented? So, did they say, this is how we did it? And they outline everything they did in developing the guideline. So go to page, for Canadians, go to page S7, and for NICE, go to pages 38 to 46, okay? And you review what's there, and you tell me, did they explain how they did it? Did they explain their methods? Try to find what methods they used to develop the guideline. Did they explain what they did?
The grading?
No, not the grading. Look through pages, 38 through 46, I think it was.
Yeah, it says
I guess, yeah, it would include how they did the grading, what the method of grading and that kind of thing. Okay? So yes, it would include that. So I see the Canadian group is finished. Is the UK group finished?
Yes.
Okay. I thought it would take longer for the UK group because there's about 9 pages of description, whereas there's 1 page of description here. That may give you a sense of what's coming. Okay. Why don't we start with the Canadians? Okay. The Canadians, here are their methods. Okay. Canadians, obstetricians, and internists knowledgeable about hypertensive disease and pregnancy, and guideline development participated. Okay, so they said we got experts together, and we invited people to do it. Then the literature was reviewed, okay, including original guidelines, their reference lists, an update from 1995. They did keywords for Medline. They searched the literature. Searches were updated by subgroup members in 2006. Articles were restricted to those published in French or English. Okay, so they're telling you we searched the literature and we used keywords, and then they have keywords in the appendix. They say what was our keyword list that we used to search, and then the concepts explored for pregnancy and hypertension were diagnosis, evaluation, classification. So the thing about these guidelines are they're about everything about hypertension and pregnancy, not just about our specific question. We will try to find the answer to our patient's question in these guidelines, but these guidelines usually are about a full range of things, right? Okay, so are they telling us anything about how they assess the quality? A focus was placed on consideration of RCTs for therapy. Why would that be? Why would they want to look mainly at RCTs for therapy instead of other study designs? Yeah, they have higher validity, right? So they're an evaluation of substantive clinical outcomes rather than surrogate markers such as laboratory values. Okay, so that's good. They were looking. And then the final grading of the recommendations was done using methodologic criteria from the Canadian Task Force on Preventive Healthcare in Table 1. And we'll take a look at Table 1. The resulting document was reviewed by the Guidelines and Perinatal Committees of SOGC, the British Columbia Perinatal Health Program, and the Obstetrics Section of the Canadian Anesthesiologist Society. Okay? Did we just bump into the answer of another question? That's the way it works. You have your questions in your head. We just bumped into the answer of another question. What's the other question? That it was in the Institute of Medicine list. Yeah. Remember the Institute of Medicine list? What was one of the things they wanted them to do for a good guideline? External reviews. External review. This is external review. So look, we don't even have to answer that question anymore because while we're searching for this answer, we bumped into the answer for another. That's what I'm saying. You need to have your questions in your head And then you're just checking them off. You're going to find the answers to this question, to that question. Sometimes you bump into the answer of another question while you're getting the answer for this one. So let's look to see if we can find table 1. Where's table 1? You know what? I think I must have removed table 1 to save paper. See, I removed some papers. Anyway, table 1. Table 1 shows them the methodologic criteria for the Canadian task force. Okay? So this is what we know basically about the methods of the Canadian. Let's look at the methods of the NICE guidelines. So this is it. First, they defined everything. Chronic hypertension is hypertension that is present at the booking visit or before 20 weeks, or if the woman is already taking antihypertensive medication when referred to maternity services. Eclampsia, HELP syndrome, gestational hypertension, preeclampsia. So they're defining things. That's the first step, what they're doing. Then they're defining mild hypertensive, moderate hypertensive, and severe hypertensive. Okay, so right up front they're saying these are going to be our working definitions throughout this document. Okay? Then I'm just scanning to see. All right. Now, what was the aim and the scope of this guideline? So now they're going to tell you what are the questions that they were actually looking at. Information and advice for women who have chronic hypertension and are pregnant or planning to become pregnant. Well, that sounds relevant to our patient, right? Information and advice who are pregnant, for women who are pregnant and an increased risk of developing hypertensive disorders of pregnancy. Management of pregnancy with chronic hypertension. Management of pregnancy in women with gestational hypertension, and down the list. So now they're telling you these are the topics that we are going to present in our guideline. Then, who is the guideline intended for? Healthcare professionals, planning healthcare services, and women with hypertensive disorders of pregnancy. Okay? And then there's a version of this guideline for women with hypertensive disorders of pregnancy. So what they did is they take these big 250 pages of guidelines, boil it down for the public to give it to the patients. So they have a patient guideline, and then this one is for the physicians and the nurses and the policymakers. Okay? Then they say, what are some other relevant documents? Okay. Who developed the guidelines? So they say 4 obstetricians, 2 midwives, blah, blah, blah. Okay? And then here, guideline development methodology. This guideline was commissioned by NICE. Do you know what NICE is? National Institute for Clinical Excellence or something like that. Okay? And developed in accordance with the process in the guidelines manual. So if you go to this website, you can find the guidelines manual. It is a detailed document, okay? And then Table 2.1 summarizes the key stages of this guideline development process. So here it is. They scoped the guideline, saying what's the guideline going to cover, prepared a work plan, forming and running the clinical development group, developing clinical questions, identifying the evidence, reviewing and grading evidence, incorporating health economics, making group decisions, linking guidance to other NICE guidelines, creating the guideline recommendations, writing the guidelines, stakeholder consultation on the draft guideline, putting it out there for anyone to comment on, finalizing and publishing, and declaration of interests. Okay? So now they're telling you how they framed it. And then they developed the clinical questions, okay? And relevant published literature to answer clinical questions was identified by applying systematic search strategies. So did they do a systematic review? Yes, that's really critical. Any guideline that did not do a systematic review, don't use it. So they did the CINAHL, Medline, 3 Cochrane databases, the NHS Economic Evaluation Database. So they did a very broad search, and I'm sure they have the search strategies somewhere in that document, which are probably just like the ones. Remember from the Cochrane systematic review, did you look at all the search terms? All those searches? That was amazing, right? I'm sure they did something very similar here. Then, okay, reviewing and grading the evidence. Okay, so here they're defining their rating score. So the EL, the highest possible evidence level, is a well-conducted systematic review or meta-analysis of RCTs. So EL1++. Okay, so this is the quality of the evidence. If it's, okay, and then if it's a cohort study, it's at level 2. So randomized trials are level 1, cohort studies level 2. It's 1++ or 1+, okay, or 1-, all right? There it is. And then level 3 is non-analytical studies like case reports, and 4 is just expert opinion. Remember that pyramid? So they're kind of, this is the level of evidence. Now, did they have a level of the recommendations? The strength of recommendation. They just have the level of evidence, but they don't have a strength of recommendation. Interesting. Remember I said you need both. There's quality of the studies, are they good studies, but yeah. See, this only has to do with low bias and increasing risk of bias, okay? All right, so that's it.
And they also have an update for that.
Yeah. So here they have the, again, levels of evidence through a 1A, B, 2, 3, and 4. But it's still not strength, okay? Okay, so now you look at this and you say, did they explain their system of developing the guideline? And was it rigorous?
Yes.
With yours? Yes. And yours, we'd have to look at their manual to see, okay? So probably both of them did a good job, I think. So shall we give A to both? Okay. Any questions about that section? You want to look at it and say, how did they explain how they did this? Was it rigorous? Did they come up with a grading system for everything? Okay? All right. Are the methods used to produce the guideline clearly documented, and are they evidence-based methods? I think so, for both of them. Now, Canada didn't really explain that much on it, but I think they said we used this other document, right? Now, did the authors search the literature with a clear strategy for all relevant studies and apply scientific rigor in synthesizing results? Okay, now both of them said they searched the literature, and if you look on page S8, let's look on page S8 for this is the search strategy for the Canadians. Pregnancy and hypertension, or hypertensive disorders, or pregnancy-induced hypertension, or, okay, and diagnosis and definition, classification, prediction, prognosis, severity, maternal mortality, maternal morbidity. I mean, look at this. Platelets, hemoglobin, hematocrit, MCV, MPV, platelet ratio. Okay, a lot of terms. So they're telling you, what's the thing that comes out to you here? Do you think they did a very limited search? No, they did a major search. This is a lot of work, what they did. And measurement, and hypertension, hypertensive disorders, and so forth. Okay? So they're telling you we did a lot of searching. Is this a systematic review? This is systematic. Systematic means they tried to get all the literature that's out there and pull it in and then assess it and evaluate it. Okay? So I think they did a good job, and the same thing goes for the UK group. I think it says it's in a separate document, the search strategy, and I never pulled that. But if they require a whole document, they did a very, very detailed search. Okay? Then, do the guidelines present an evidence-based system for assessing the quality of the evidence and the grading of the strength of the evidence, of the recommendations?
Quality, yes, for sure.
Okay, so UK, we already looked at the UK, right? It's mainly quality, not the strength of recommendations. Why don't you look on page S2 and in the Canadians and see what you see? What do you see on page S2? Yeah, isn't this interesting? This is page S2. The quality of evidence assessment. So what I expect here is things about bias. Less biased, more biased. Let's see. Evidence obtained from at least one properly randomized controlled trial. That's level 1. That sounds a little weak for level 1. I would say, where's the systematic reviews of multiple trials? A little disappointed in that one, but anyway. Evidence from well-designed controlled trials without randomization. So that's less. It's controlled trials, but not randomized. Again, putting it at this is level 2. Then level 2 is evidence from well-designed cohort or case control studies. Evidence obtained from comparison between times or places without the intervention and with the intervention. Okay, so they're saying least biased and with increasing risk of bias. Then over here, the classification of recommendation, that's different than saying what the quality of the evidence is. The quality of evidence just says, what's the risk of bias here? But are you going to recommend it or not? That's a different story, because you have to look at the magnitude of the association, you have to look at side effects, you have to look at acceptability and cost, economic evaluation. Like, there's a lot that goes into whether you recommend it or not. It's not just whether this was a randomized controlled trial. Okay? So, A, there's good evidence to recommend the clinical preventive action. B, there's fair evidence to recommend the clinical preventive action. And then C, there's conflicting evidence, which we cannot make a...
So ABC is what it's their opinion about what they've read?
It's the strength of how much they think that the clinician should act on. If you have grade A recommendation, it means we really think you should consider this. It's good evidence.
So this is objective and this is subjective, right?
Well, maybe, okay. Yeah, this is just, are the studies out there high quality or low quality?
Yeah, and this is what they
This is, do we think you should do it or not do it? How strongly do we say you should do it? If it's B, it's like, well, it's maybe a little more acceptable not to do it. But if you decide not to do something that's grade A recommendation, you better have a good, think it through and make sure that you have a reasonable clinical reason not to do it. It doesn't mean you have to do it. It's just saying, this means there's good evidence that we should be doing this, okay? And D, there's fair evidence to recommend against it. So you should not be doing this. Consider not doing it. And then there's insufficient evidence to make a decision. Okay, so do you give them an A or a B? The Canadians, A. What about the
We didn't see the strength.
no, we didn't see strength. We only saw quality of evidence. So we'll give them a B or a C. You know, to make up for the C's over here, we'll give them a C. How about that? Okay, okay. All right. Okay. What's next? So do the guidelines present evidence-based system for assessing the quality of evidence and the strength of the recommendations? Okay. Now, Was the guideline subjected to outside review?
Yes.
We already answered that for the Canadians. What about the NICE guidelines? Look on page 45 from the UK side, okay? And you tell me what you see about that. Look on page 45. Does it say anything about letting other people look at your guideline before it gets published? So we have an A already here because they've sent it out to at least 2 other organizations to review, right? Or an A minus. Let's give it an A minus because now look what did they do? What did UK actually do?
Stakeholder
Organizations were invited to comment on the draft document. The committee responded to all comments and all correspondence published.
Yeah. So the group actually got comments from all these stakeholders. They wrote comments on them. And what did they do with the comments and the responses? What did they actually do with those? Look. They were reviewed independently by NICE for a guidelines review panel and are published on the website. So anybody can look and say, oh, that group over there made this comment, and then this NICE guidelines either accepted and said, you know what, you're right, we will change our guideline, or sorry, we're not changing our guideline for this reason. You see? On the website, they actually published all of this. They said, here's the comment from this organization, and this is our reply. See, remember that first one in the IOM? Transparency. You know, you may not like what their response was, but at least you know what it is that they responded to them. And you see, the problem with guidelines are there's money. There is money involved in this because of pharmaceutical companies and all this, you know, guidelines for, you know, anything. So that's why it's so important to be completely transparent. And then you have some people writing, we think that there's undue influence by this, that drug company, Roche. And so they might say, well, on anything that had to do with a Roche drug, this person recused himself from the discussion. Or something like that. Like you can have any comment coming and then a response to it. Okay? All right. So then, are the recommendations made in clear, clinically important statements? Okay? So you look on page S2 to S6 and try to find the recommendation for our patient. What was our patient? Mild hypertension treatment in first trimester, okay? And then in the NICE guidelines, do the same thing. Go through pages 1 to 6 and see if you can find the recommendation for our patient, and you tell me, is it clear what I should do with this patient, okay? Should I keep treating with beta blocker, or should I change to something else, or what? What page is it on?
40 to 4. It says points, and each one of them has the quantity and the recommendation for each.
Okay. So is it this right here, down in this area? Okay. Have you found your recommendations, NICE, UK? It's page 1 to 6, right? What page is it on? Is it page 6? Page 6, yeah. Okay, let's read the guidelines from UK. And is it this one here, treatment of hypertension? Or is it before that?
Yeah, but there is also in page 5.
Page 5, let me see. Pre-pregnancy advice.
Management.
Yeah, I mean, I think it's here, treatment of hypertension. Now, how clear is this? So, in pregnant women with uncomplicated chronic hypertension, aim to keep blood pressure less than 150/100. Okay? So, they're saying don't treat down to normal blood pressure necessarily. Just keep the blood pressure below 150/100 in uncomplicated hypertension, which is our patient. Now, do they say anything about what to treat with? Not here. Do not offer pregnant women with uncomplicated chronic hypertension treatment to lower diastolic blood pressure below 80. Fine. That's clear. Offer pregnant women with target organ damage. We don't have that. Offer pregnant women with a secondary chronic hypertension referral. That's not us. Offer women with chronic hypertension antihypertensive treatment depending on pre-existing treatment, side effect profiles, and teratogenicity. Are these guidelines really clear? I'm having a little trouble. I mean, okay, fine. Offer women with chronic antihypertensive treatment. I know she's on beta blockers, but side effect profiles and teratogenicity. I need to know, just from my own knowledge, that ACE inhibitors, right? I know from medical school, don't treat pregnant women with ACE inhibitors, right? You remember that?
Yeah.
Yeah. Okay. So, okay, where does it say here?
Page 5.
Page 5.
Tell women who take ACE inhibitors or angiotensin II receptor blockers there's an increased risk of congenital abnormalities if these drugs are taken during pregnancy. Okay, good. So they're at least telling us this. But I wish they would tell us that in the guideline part where they're saying about teratogenicity, right? So to discuss antihypertensive treatment with the healthcare professional responsible if they're planning. Stop antihypertensive treatment in women taking ACE inhibitors or ARBs if they become pregnant. Okay, so, okay. Well, this is their guideline. These are their guidelines. Meaning, give this advice before they get pregnant. If there's a woman on ACE inhibitors who's of childbearing age, you tell them, look, if you're planning on getting pregnant, or if you could get pregnant, you need to stop this, or maybe let's switch you over to something else. Okay? Now, let's look at the Canadian guidelines. And
Quite clear.
yeah. So here, recommendations for antihypertensive therapy for non-severe hypertension, blood pressure of this to this over this to this. Okay, so already I'm feeling a little, you know, like something good is coming. For women without comorbid conditions, antihypertensive drug therapy should be used to keep systolic blood pressure at 130 to 155 and diastolic blood pressure between 80 and 105. So this is similar to what UK said. Keep it below 150 over 100. Now they're saying you can push it a little higher here, but don't go below 80. That was from the UK. Okay, then it says for women with comorbid conditions, antihypertensive drug therapy should be used to keep blood pressure. Oh, that's if they have comorbidity. Initial therapy can be with one of a variety of antihypertensive agents available in Canada. Methyldopa, oh, they're saying 1A. Oh, there was a 3C. Labetalol, 1A. Other beta blockers, 1B. Calcium channel blockers, okay. ACE inhibitors and angiotensin receptor blockers should not be used. 2E, okay. Atenolol and prazosin are not recommended, 1D. Now, clarity of guidelines. Would you give Canada an A or a B or a C? A. How about NICE? Yeah.
Another page in 6.2.
Yeah.
We have table and everything.
Yeah.
side effect and also recommendation.
Okay. Yeah. Yeah. In page 62.
Yeah.
Yeah. But see, this is their summary, and I don't like their summary because the summary doesn't give you the things that you need. Here, let's see. But he's going to defend. He's going to defend the NICE guidelines. See up here, this is like a summary of the recommendations. But let's go, what page did you say?
62. Yeah, this one.
Okay. So here, ACE inhibitors, pre-pregnancy advice.
Yeah.
Now, so they have a lot of statements here, but again, it's not bulleted. Like here they say a retrospective cohort study in the US investigated safety of ACE inhibitors, and then another study conducted. It's like mu'akkad. It's a lot. You know, give me the zibda here. I need the zibda, right? Angiotensin II blockers, and then, but here, let's see, methyl-dopa. So these are recommendations. Methyl-dopa, mild hypertension in babies in the first 2 days of life. This is safety data, okay? Anyway, and the level of evidence, they just keep giving you the quality of evidence, not the strength of recommendation. Do you see? So there's a lot of information here, but it's not laid out so clearly. It needs to be more clear. Would you agree? I mean, when you look at that versus that, there was more thought given to streamlining the advice in the Canadian one than in the other one. Okay, so that's basically what you're looking for. Then, does each statement have a strength of recommendation indicated? The Canadian side, it did. Over here, they're not. It's a little. You know, what do you call it? Mushakkal, right? A little tikka and a little kebab. Sometimes you see the 1+ and sometimes you see the 2E. But this one, there's like consistent, you know. Yeah. Okay. Now, lastly, well, maybe not lastly, but is there a plan for updating? Is there a plan for updating this recommendation? I'm not usually that funny, but they're really, I think it's late in the afternoon and Thursday and time to go home. Anyway, look on page S7 and page 46 over here, and you tell me, is there a plan for updating? Is there a plan for updating? Can you find a plan for updating anywhere? The Canadians, I'm having trouble finding something. On page S7, I thought I had seen something in there before that might, but can you find anything on what they're saying? We're going to redo these guidelines in the year 2015 or 16. How about with the NICE? Yes, there is. They have definite plan.
46.
Page 46, huh?
And the table itself, 2007, 2009, you have to.
Yeah. Right, 44, 45. Schedule for updating the guideline, okay. So you look at that and you say, they're published with a review date 3 years from the date of publication. How long do you think it takes to do all this work? 2 years. I mean, it's a lot of work. All those people meeting and making guidelines and doing all that work. So they're constantly doing this because it's they may get a little break and then they have to start already on the new one, redoing the literature searches and all of that. Okay. Then let's look. Does the guideline clearly describe the target population? I think both of them clearly say pregnant women with mild, what do they mean by mild hypertension, etc. Does the guideline clearly address my clinical question? We already did that, right? Yeah, clearly it does. Were all important outcomes considered? So you have to look, but did they consider teratogenicity? Did they and intrauterine growth retardation and low birth weight and maternal outcomes, eclampsia, preeclampsia? We saw they considered all of it. Was there a consideration of cost effectiveness? Not for our question. I know the NICE guidelines had cost effectiveness for other things, but not for our question. Are the recommendations relative to my local situation? Kuwait. What do you think? What about using guidelines from the UK here in Kuwait?
My personal opinion, we are genetically different, so I don't think their guidelines is applicable to us. But this is what we are doing.
Why do you need any pregnant women?
Right. The thing is, well, there's two different sides to this. One is, if you cut a British person's finger, what color is the blood? Red? The same as Kuwaitis? So you could say, look, most treatments work the same in human beings, but there always is a possibility that things may not work the same because of genetics. Okay.
For rheumatoid arthritis, it
Yeah.
works perfectly there, not here.
Okay, so there may be things like that you have to be aware of. Another thing is the situation in the UK, the prevalence of certain things, the behaviors are different than here. So be careful about just dropping guidelines from over there and using them here. You have to put them in the context of Kuwait, Kuwait's needs, Kuwait's priorities, Kuwait's problems, Kuwait's issues. Don't just reflexively do that. Now, there's one more paper. Let me see if I can find it. And we'll quickly go through this. This one is the one that your friend, are we supposed to be finished 3:15?
Yeah.
Okay, then there's another one here. You can take a look at it. But it follows almost none of them. It doesn't say who did it. There's no, very little definition. It's just a bunch of guidelines. But all those things that we went through, what was the method they used? Did they do a systematic review? Was there external review? Was there more than one person who did it? Is there a plan for doing it again? Nothing is there, okay? So you can take a look at it and say, yeah, I'd rather go with one of those two, okay? So that's how you critically appraise guidelines, okay? Thanks. Yeah, thanks for your attention.